All right, guys. Let's go ahead and let's get started on peripheral nerves here. So here's what we're going to cover. We're going to cover exactly what a nerve looks like, and then we're going to dive into our two major groupings of nerves, the cranial nerves and then the spinal nerves. And just a quick reminder, a nerve is simply a collection of axons, right? That's what we call a collection of axons in the peripheral nervous system. We call a tract a collection of axons in the central nervous system. So I'm going to split this lecture up into two parts. This first part will contain the structure of a nerve, and it'll cover the cranial nerves. The second part will cover the spinal nerves. You should recognize this slide here. This is our kind of our outline of how our central nervous system and peripheral nervous system are connected. I'm going to skip the subdivisions of the peripheral nervous system because hopefully we know that pretty well by now. I'm going to focus on the connections, and just again, hopefully it's a reminder. We have 12 pairs of cranial nerves that come out from our brainstem, that come out from our midbrain, that go to the organs of our head and our face. So that's one of the major connection points between our central nervous system and peripheral nervous system is our cranial nerves. We also have 31 pairs of spinal nerves that connect our spinal cord, and therefore midbrain and brainstem, to the rest of us. And maybe you even remember the numbers of spinal nerves that we have. Remember, we have 8 cervical spinal nerves, 7 plus 1, 5 thoracic, 5 lumbars, 5 sacral, and 1 tiny little pair of coccygeal spinal nerves. And here's just a look at those, at where those nerves come from. So over here on the left, this image on the left, that is that's a view of our brainstem. Oops, sorry about that. Hopefully it didn't startle you. That's a view of our brainstem. And the little yellow parts right here, those are those cranial nerves coming out of the brainstem. And your cranial nerves originate from nuclei in the brainstem, from cell bodies, right? Because the nerves themselves are the axons. The cell bodies have to be sitting somewhere. Most of your cranial nerves do end up coming out of the medulla oblongata, though there are some coming out of the brainstem. If we look at the spinal nerves, here's our numbering again, 8, 12, 5, 5, and 1. And it's the axons that form the nerves themselves, but we have gray matter, we have nuclei, or they're actually called horns, of the spinal cord. So again, cell bodies in the gray matter, axons in the white matter. We just call the gray matter and white matter different things, depending on whether we're talking about spinal cord or brain in this case. So it's called horns in the spinal cord, and it's called nuclei in the brain. These nerves, when they come out of our spinal cord and our brain, they're big. They're bigger than you think. Here actually is a view of some of the nerves in our body, and these aren't necessarily the biggest nerves. They're kind of, they're on the bigger side, but they're not huge. This is the shoulder. That's a deltoid muscle. This is the biceps brachii muscle right there. Here's the clavicle outlined right there. And these white things right here, those are all nerves in there. So they're very big. I remember when I first saw this, I was kind of like, whoa, those things are huge, right? And this is by the way, this is a cadaver image of a human cadaver. This white part right here, that's fascia right there. Nerves do have layers, just like everything else in us, all right? And the covering of nerves is also known as deep fascia. Maybe you remember that, but we rename that deep fascia depending on location. And the outer covering of nerves, its specific name is epineurium. Epi means on top of, so that part kind of makes sense. We can subdivide our nerve into groups of axons. Let me show you a picture here of this actually. So here's an entire nerve, the entire diameter of a nerve. This wrapping on the outside, this is our epineurium. This grouping of axons right here, that's called a fascicle. That's called a fascicle. Right? And there's a spelling there, it's kind of a bizarre spelling, fascicle. And within that fascicle, we have all of our individual axons. Each individual axon is wrapped let me go backwards, sorry. Each fascicle is wrapped by perineurium. Peri means around. And then each individual nerve within that fascicle is wrapped by endoneurium. Endo means within. You can even see this on the microscopic scale too. Look over here at this image down there. You can definitely see that epineurium around the outside. You can see the subdivision between the fascicles right in there. You can't really see the endoneurium in this particular image. It's a little too small. We'd have to zoom in more, but it's there. Now, why do we need an additional layer of tissue in there? And keep in mind, this is all connective tissue. We're talking about fascia. This is dense irregular connective tissue. Why do we need that additional layer of dense irregular connective tissue around every single frickin' axon? Well, it's all about insulation. Remember, these guys are busy spraying ions and neurotransmitters everywhere, and, well, that endoneurium wraps that whole mess up and makes sure that those ions don't leak into other nearby neurons. And those other nearby neurons, maybe they're going to convey similar information. It might be a pain neuron, it might be a touch neuron, or maybe it won't. It might be a motor neuron that's right next door. So we want to make sure that whatever information is going along that action potential doesn't accidentally spill over into the next neuron. And that's another important point to make about these nerves. Each individual neuron here is going to convey its own information. Nerves can carry neurons of all different types, motor neurons, sensory neurons, doesn't really matter. You can carry everything in there. All right, so that's our layers of tissue coverings of nerves. We got epineurium on the outside, perineurium surrounding our fascicles, and then endoneurium insulating each individual axon. Let's go into our cranial nerves now. So this is kind of our first major set of nerves. Generally speaking, your cranial nerves supply your cranium. Go figure! It's not just your cranium though, it's your face, your neck, even down to your upper back, like down the back of your neck, and kind of to your shoulders too. So there's they do reach pretty far. And these cranial nerves, just like we said, they can carry a mixture of information, sensory, motor, both. And cranial nerves, except for actually number 11, as we'll see, 11's a weird one. All of your cranial nerves will originate somewhere in the brain stem. So somewhere in the medulla oblongata or in the midbrain. All right, that's the picture that we saw over here, is our brain stem and our cranial nerves coming out from there. And because these cranial nerves can carry motor information, they can carry both somatic and autonomic motor. And on our spinal cord drawing, you may recall that there is those autonomic neurons, the preganglionic and postganglionic neurons. Well, remember they have a little pit stop somewhere along the way? Where they make that pit stop is a ganglion. So those cranial nerves that have autonomic neurons, they're going to make that little pit stop in a ganglion. Let me show you a picture of what these ganglia look like in relationship to cranial nerves. So right here is one of the big ganglia. It's called the trigeminal ganglion, and it carries the trigeminal nerve. Specifically, it carries autonomic information for the trigeminal nerve. The trigeminal nerve is one of our 12 cranial nerves. Here's another one, teeny tiny little guy down there. It's called the submandibular ganglion. Hey, submandibular, underneath the mandible, kind of. Well, that kind of makes sense if you squint. And this size, by the way, is pretty accurate. The trigeminal ganglion is pretty monstrous. They can get pretty big. I don't know if you noticed this particular structure here. That is our pituitary gland. So the trigeminal ganglion does rival the size of our pituitary gland. And hold on just one moment, guys. Alright guys, sorry about that. That was kind of an awkward edit there. Let's pick up where we left off. Okay. So now we're diving right into the cranial nerves. Okay. Here's actually a really gorgeous picture. Somebody put a lot of time and color into this, of the origin points of all of the cranial nerves. And the major takeaway from here is that yes, they are in pairs, right? You do have one for each side of your body, and some of them are a lot bigger than the others. Like look at this guy, the trigeminal nerve, and it is the same one that we just saw that forms the trigeminal ganglion. He's one of the biggest cranial nerves. Optic nerve is another big guy up here. So this is just to kind of give you a reference point for, kind of what this looks like. And I'm going to run through the pronunciation of these just really quick. So this is our first cranial nerve right here. That's the olfactory nerve. Our second cranial nerve, optic nerve. Third cranial nerve, oculomotor. Fourth cranial nerve, trochlear. Fifth, trigeminal. Sixth, abducens. Seventh, facial. 8, vestibulocochlear. 9, glossopharyngeal. 10, hypoglossal. 10 is not hypoglossal. 10, vagus. 11 is the accessory, and then 12 is hypoglossal. All right. You probably notice some repeated words here. Glosso means tongue. So hypo, beneath the tongue. Glossopharyngeal means tongue and throat. So you can probably guess as to where some of these are going to go. In order to remember which numbers are which, there's a mnemonic here, and if you don't know your Roman numerals, here's a chance to learn them. The olfactory nerve is also called cranial nerve number 1. Optic is cranial nerve number 2, number 3. Oculomotor number 4. Trochlear. You guys got the rest of it. In order to remember the number of each and the name, here's a little mnemonic. On occasion, our trusty truck acts very funny. Very good vehicle anyhow. That's not a great mnemonic. There's a lot of others out there that are way dirtier and therefore way more memorable. But, I'll let you find those. We also do have to know what types of information these nerves carry. So, as an example, the olfactory nerve is all about smell. So it just carries sensory information. The optic nerve is all about sight, just sensory. The oculomotor nerve, however, carries information to control where your eyes point. So, motor. Some of them, like the vestibulocochlear right here. Oops, sorry, not the vestibulocochlear. The facial. Some of them, like the facial nerve, carry both sensory from the face and motor to the face. So in order to remember which are sensory, which are motor, and which carry both, here's another mnemonic. Some say marry money, but my brother says big brains matter more. I usually cross off brains and put boobs. Big boobs matter more. If I wasn't willing to give you another better mnemonic for the trusty truck one, you can imagine how dirty those are. Okay, let's dive into cranial nerve number 1, olfactory. Right here is a cross-section of your head. Down here, here's your mouth. Specifically your oral cavity. Up here, here's your nasal cavity. All right. And this right here, this is the olfactory nerve. Notice how the olfactory nerve comes from this general area of the brain, and that general area of the brain, I promise, is the limbic system. So your olfactory nerve does route through the limbic system. And from this bulb up here, this is called the olfactory bulb, right there, we have little axons dangling down from the olfactory bulb. Those little axons go through the holes in the cribriform plate right here. Right? Remember that cribriform plate of the ethmoid bone? Well, there's where your olfactory nerve axons go. So this guy is sensory only. And if he's sensory, what kind of sense does he convey and what part of the body does he supply? He supplies smell. Smell from the nasal cavity. Is there anything else that's particularly interesting or important about this? Well, the olfactory bulb is right here, right underneath the frontal lobe. This is the only cranial nerve to go this far front, or be this close to the frontal lobe of the brain, I should say. You can damage this nerve when you break your nose. So if you break your nose or even your cheek, you can lose your sense of smell, which is, I guess, could be both a blessing and a curse. Depends on how you look at it. Number 2 is the optic nerve. And the optic nerve comes straight from the back of the eyeball. So this entire thing right here, this is all the two parts, the two halves of our optic nerve. And our optic nerve takes a kind of convoluted route as it gets back to our primary visual cortex back here in our occipital lobe. We'll learn more about this when we learn about the eyes. Well, Dennis will talk about the eyes with you. But here's the short of it. Your optic nerve comes from the back of the eyes. Half of the information that comes from the optic nerve is going to cross over. The other half is actually going to stay on the same side. So, some information is going to get to one side of the brain, some of it's going to get to the other side of the brain. And the reason why we do that is so we can compare information coming in from one eye versus the other eye. And by comparing information, we can generate a three-dimensional image. The images that come in your eye and that hit your retina are slightly different from your right eye to your left eye, because your right eye and your left eye are offset from each other, right? So in order to compare and find the difference between the two and therefore generate a three-dimensional image from those differences, we need input from both eyeballs onto the same side of the brain. So by kind of splitting off information this way, that's what allows us to do that. All right. So, as we just said, it's sensory. Remember, some say marry money, sensory information for sight. It supplies the back of the eye. We call the back of the eye the retina of the eye. And it has a fairly convoluted route that it travels. Your optic nerve it crosses right here at the optic chiasma. And by the way, here's where a pituitary gland would be, right underneath the optic chiasma. It then forms what's called the optic tract right here, before synapsing in the thalamus back here. And from the thalamus, that's where we finally go, that's where our thalamus finally routes us to our primary visual cortex. Okay, so this is something that, again, you'll focus more on when you get to the eye in more detail. All right, so with this one, obviously, if you damage it, you lose your sight. And this is, weirdly enough, this is the only cranial nerve that is affected by multiple sclerosis. Your other cranial nerves are safe. Your spinal nerves, totally screwed. Cranial nerves, though, are safe from the effects of MS, except for the optic nerve. Don't really know why. It's just a thing. Let's go on to our oculomotor nerves. So based on the name, oculo, eye, motor, movement, cool. These nerves convey motor information in order to control where your eyeball points. And how do we control where our eyeball points? Well, it's all based on muscles that we have that are attached to the surface of the eye itself. So I just highlighted in that red X, that's an attachment point. And these muscles, they're skeletal muscles, but they're teeny, teeny, tiny little skeletal muscles. They're like maybe half the size of your pinky. I'm looking at my pinky trying to figure it out right now. So they're pretty small. And let me see if I have a better picture of the eye. No, I don't. Shoot. Okay. Well, if we were to draw your eyeball, here's your eyeball. It's kind of a astigmatic eyeball right there, weird shape eyeball. You have muscles that attach on one side and the other side. We call these muscles that attach on the side the medial and lateral rectus muscles. Medial rectus muscles right next to your nose, lateral rectus muscles right next to your tear duct closer to your ear, right on the medial lateral sides of your body. Go figure. We also have a muscle that attaches directly at top, and then a muscle that attaches on the bottom too. We call those the superior and inferior rectus muscles. So again, it makes sense. Superior up top, inferior on the bottom. And then we have two additional weird ones. We have two additional muscles that pull at an angle. So these muscles right here, I'm highlighting it on this image. That muscle right there, that's one of them. And then we also have another muscle down here. Here's the other one. Those are called the oblique muscles. All right. So we have the rectus muscles, medial, lateral, superior, inferior. They just pull straight, kind of like your rectus abdominis, right? They just pull your trunk up straight. And then we have the oblique muscles. They pull your eyeball at an angle. So when would you be using your rectus muscles, and when would you be using your oblique muscles? You'd be using those obliques when you're reading, right? When you're rotating your eyes at an angle as you're reading a sentence. You'd be using those medial and lateral rectus muscles when you're reading too, but medial and lateral you'll use maybe when you're driving, right? When you're watching other people on the road, trying to predict what they're going to do. Okay, but that's just, again, just kind of an introduction to those muscles. Now, our oculomotor nerve doesn't just control those muscles. And, by the way, one thing to keep in mind, these terms extrinsic versus intrinsic, maybe you already know what it means, maybe you don't. Extrinsic means on the outside. Intrinsic means on the inside. So those muscles that we just named, the rectus muscles and the oblique muscles, those are extrinsic muscles. However, you also have smooth muscle on the inside of your eye. The extrinsic muscles are skeletal. The intrinsic muscles are smooth muscle. And those intrinsic muscles control your pupil dilation and your pupil constriction, and they control the shape of your lens. So your oculomotor nerve controls 4 of those 6 extrinsic eye muscles. Remember, 1, 2 on the side, medial and lateral side, 1 on top, 1 on bottom, and then 2 angled, 6 total. Oculomotor controls 4 of them. And it supplies parasympathetic control for both your intrinsic eye muscles. There's 2 intrinsic eye muscles, one that controls your pupil and another one that controls your lens. Interestingly, it'll also carry a little bit of sensory information for proprioception. So you kind of know where your eyeballs are pointed at, even if you close your eyelids, right? Because of the sensory information conveyed by the oculomotor nerve. Now that sensory information is pretty minor, so a lot of times you'll just see oculomotor classified as just straight up motor, and that's what we're going to mostly stick to. Oops. Hey, want to friend me on Steam? Okay. So that's what we supply our extrinsic eye muscles and our intrinsic eye muscles. What does our oculomotor nerve control? Well, pupillary constriction, right? That's our intrinsic eye muscles. They'll help control eye movement, and interestingly, because we control eye movement, we'll also control the position of our eyelid too. So if you paralyze this oculomotor nerve, well, you're not going to be able to see very clearly. You're going to have double vision. You're not going to be able to possibly control one eye, resulting in something called lazy eye, where one eye doesn't quite look at the same thing as the other one does, and your eyelid might droop. Just depends on exactly what the damage is. All right, that's number 3. Let's look at number 4, the trochlear nerve. And I know you're thinking, hey, trochlea? Humerus? Not really. Sorry. A trochlea means a little hook. So in that regard, yeah, kind of, but here it's a little hook of bone in the case of the eye. So your trochlea is this little hook of bone up here, and the trochlear nerve will supply the single extrinsic eye muscle that goes through that little trochlea. Yes, the oculomotor nerve supplies 4 of the 6. The trochlear nerve just supplies 1 of the 6. We're set up really dumb. Evolution sucks. So this guy is going to control an extrinsic eye muscle. If it's extrinsic, it's skeletal. If it's skeletal, it's somatic motor. It does, at least for the somatic motor part, much the same thing as cranial nerve number 3. And if you damage it, you get the same effects, some of the same effects as cranial nerve number 3. You get double vision. You might have trouble reading. I don't know if you noticed, but that trochlear nerve controls one of the oblique muscles. Remember we said the obliques are used in reading. So if you damage that, you might have trouble reading, especially if you're like looking at something in your lap. All right, let's look at number 5, the trigeminal. This one's one of my favorite. He's so cool. So the trigeminal nerve is the biggest cranial nerve in ya. And he synapses right next to your ear in the trigeminal ganglion. And the trigeminal nerve is so big, he actually splits off into 3 parts. We call it branch 1, branch 2, and branch 3, or V1, V2, and V3. And there's kind of an interesting story behind this. The trigeminal nerve is number 5, right? And so somebody got smart and said, oh, let's call it 5 branch 1, 5 branch 2, V for 5, 5 branch 3. And along the way, people just stopped calling it 5 branch 1. They just started calling it V1, V2, and V3. So there you go. You don't have to know the names of each of these branches. You just have to know that there's 3 of them. And you also have to know approximately where they go. So V1, or the first branch, innervates or supplies information from the nose all the way up to the forehead. V2 supplies information from the maxilla, and then V3 supplies information from the mandible all the way up the sides of the face. So this guy is the major nerve that supplies sensory information from the face. One thing to keep in mind here is it supplies sensory information from the center, mostly from the center of the face. From the sides of the face, we have another nerve, the facial nerve, number 7, that's going to supply a lot of the side. Trigeminal nerve focuses around the center. So it supplies sensory information, and it also supplies motor information to the face. Motor information specifically to those chewing muscles, to the temporalis, to the masseter muscles. All right, so this is the one that controls a lot of chewing, a lot of eating. And if you gotta have dentistry work done, you're gonna numb this guy. This trigeminal nerve is widely used in dentistry. When you go in, you get those numbing shots, they're aiming for branches of the trigeminal nerve. And it's this trigeminal nerve that passes through those little holes in the skull. The mental foramen down near your chin, the infraorbital foramen underneath your eyes, and the supraorbital foramen above your eyes. If you damage this guy, well, you're going to have no sensory information coming in. So you're going to lose sensation to the face. You, again, depending on the extent of the damage, you may lose your ability to chew, or you may have weakness in chewing. Now this trigeminal nerve, because it supplies so much sensory information, if you damage it, and damaged neurons scream out in pain, you can have what are called cluster headaches. The nickname for them is suicide headaches. They are one of the most painful conditions known to man. So cluster headaches are also called trigeminal neuralgia. Neuralgia is anything that's caused by neurons going haywire. And how do you get trigeminal neuralgia? Usually it's from like a surgery or something gone wrong, or from a traumatic injury. I've had one student in the past who had trigeminal neuralgia or cluster headaches from a dentistry procedure that went wrong. And that scared the you-know-what out of me. Okay, so that's our trigeminal nerve, sensory and motor. Those of you guys wanting to be dentists, this is going to be your best friend and your worst enemy, this nerve right here. Let's move on to the abducens nerve, number 6. So number 6 is kind of like number 4 and number 3. So 3, 4, and 6 all control these extrinsic eye muscles. Yes, we're back to the eye again. So number 6 controls just one of these. Just like the abducens controlled one of these, just like the trochlear controlled one of these, the abducens also controls one of these. Who controls the other 4? Oculomotor. All right. So he's similar in what he does to cranial nerve number 3 and 4. So 3, 4, and 6, those are the ones that control those extrinsic eye muscles. And if you can't properly coordinate those eye muscles, your eyes can't focus, you're going to get double vision, you're going to get drooping eyelid, most of those symptoms that we talked about earlier. Okay, let's look at number 7, the facial nerve. So the facial nerve supplies a lot of the sides of the face. The trigeminal is kind of the center of the face. The facial is a lot of the sides of the face. And your facial nerve has 5 branches. You don't have to know those branches. Okay, but it is big enough to kind of warrant its own branch naming here. What does your facial nerve supply? Well, it supplies most somatic and autonomic motor control of the face. The trigeminal controlled your chewing muscles, right, the masseter and the temporalis. The facial nerve controls pretty much everything else. So when you smile, not really much, when you wink at somebody, that's the oculomotor. But when you smile, when you... I'm trying to think of other facial movements and I'm failing here. Hopefully you get the idea. You're using the facial nerve there. What kind of autonomic control do we have though? Well, tearing, right? Production of tears is motor, and that we don't, most of the time, don't have conscious control over. That's autonomic. That's controlled by the facial nerve. Right? Saliva production is controlled by the facial nerve. That's autonomic. We're also sensory here too, weirdly. We supply sensory information from the tip of the tongue. So stick your tongue out and touch the tip of your tongue. That taste information is being conveyed by the facial nerve. Because this facial nerve supplies so much of your face, if you damage it, there's a lot of things that go wrong. And the most common source of damage is actually a viral infection. Usually the virus is HSV, herpes simplex virus. When the virus infects the facial nerve, it usually only infects one side at a time. So that infection of one side at a time is called Bell's palsy. And you prevent the facial nerve from communicating, so you cut off most motor supply. You don't have a blink reflex. The corner of your mouth droops. You can't really smile too well. You get dry eyes because you lose autonomic control. Loss of tearing. You can't wrinkle your forehead. You can't make a lot of facial expressions. By the way, this is different from how Botox works. HSV paralyzes the nerve supply. Botox works by paralyzing the muscles. In Botox, your facial nerve is still firing. Right. With Bell's palsy, by the way, most people do recover after several months. It takes some time, but most people do make a full recovery. All right, let's go on to number 8, the vestibulocochlear nerve. So let's break down this heck of a name here, vestibulocochlear. Vestibulo means balance. Cochlear means cochlea. The cochlea is the part of your ear that helps you hear things. So this little snail shell right here, that's the cochlea. And then these loops right here, that's part of the vestibule. So your vestibulocochlear nerve supplies both. Cochlea is for hearing, vestibule is for balance. And we carry sensory information back to the brain about hearing and balance with this cranial nerve number 8. All right. And if you damage this nerve, you get hearing loss, right? Especially if you damage the cochlear branch. You get loss of balance, and because you lose your balance, you get nausea, you get vomiting, you don't feel so good. There's something that's really, really interesting with your ear though, and specifically with the vestibular branch. You can fool the vestibular branch. Say you have like really bad nausea, really bad vertigo. You can actually do some exercises that fool the vestibular branch into thinking that you're upright, and you can retrain your brain to not have vertigo anymore. And these exercises take like 15 minutes. So most good physical therapists will know these exercises, and they're fairly common, especially for old people who don't have good balance anymore. Okay, let's look at number 9, the glossopharyngeal nerve. Glosso, remember, meant tongue. Pharyngeal, well, kind of like pharynx, right? That refers to the throat. So your glossopharyngeal nerve will supply your tongue and also your throat, but not just your throat. It'll supply the blood vessels that run next to your throat too. There's a big old honking blood vessel in there, and that's the carotid artery. So your glossopharyngeal nerve will carry information from the carotid artery. What type of information? Oh, a lot, as it turns out. So let's go through this. Your glossopharyngeal nerve will help you with swallowing. The back of your tongue is what flips food into your throat and into your mouth, and it's what initiates the process of swallowing. So if your glossopharyngeal nerve is damaged, you can't swallow too well anymore. You lose your swallowing reflex. Your glossopharyngeal nerve will also supply some of your salivary glands too. So autonomic motor control of your salivary glands. And I know you're probably going, hey, wait a second. We just said that was the facial nerve. What gives? Well, we have 3 salivary glands. Glossopharyngeal supplies one of them. Facial nerve supplies the other 2. So that's why. And what about sensory? Well, your glossopharyngeal nerve will convey taste from the posterior tongue. Remember, facial was the anterior tongue. Glossopharyngeal is posterior. And here's the really interesting part and the important part. So if you were dozing, wake up. Because that glossopharyngeal nerve runs right next to the carotid artery, the neurons there can dip into your blood supply, and they can sample oxygen levels, carbon dioxide levels, heart rate, even blood pressure, and feed that information back to your brainstem. So when you regulate your blood pressure, when your brainstem, your medulla oblongata, the vasomotor center of your medulla oblongata, to be specific, when it regulates blood pressure, it does so because it's receiving information from the glossopharyngeal nerve. This is going to become so important next quarter when you talk about regulating blood pressure. Okay. One of the things that happens with your glossopharyngeal nerve is if you have consistently high blood pressure, right, if you're not very healthy or whatever, eventually it'll get used to that consistently high blood pressure. It's kind of like the boy who cried wolf here. And it'll stop sending signals telling you to try and lower your blood pressure. So you're stuck with that high blood pressure and you develop hypertension and some of the damaging effects from hypertension. All right. So if you damage this, well, you're going to develop hypertension, but that's next quarter. More for us, you actually lose your gag reflex, weirdly enough. So how do you damage your glossopharyngeal nerve? Well, if you damage your throat in some way. Okay. Number 10, the vagus nerve. The vagus nerve is another really, really important cranial nerve. And just looking at the picture here, you can probably guess why. The vagus nerve is well named. Vegas, not to be confused with Las Vegas. Vegas means vagabond. And vagabond means wanderer, someone who wanders all over. And the vagus nerve is the only nerve that wanders out of the head down into your abdominal cavity. It supplies your heart, supplies your lungs, your stomach, your liver, your kidneys, even your freaking spleen down there. So your vagus nerve conveys huge amounts of information to almost all of your internal organs. And what type of information? Your vagus nerve is responsible for about 90% of your parasympathetic nervous system. Remember, parasympathetic, sympathetic. Parasympathetic slows you down. Sympathetic speeds you up. Well, your vagus nerve is what's responsible for slowing you down and helping you relax. Your vagus nerve will tell your heart rate to slow down. It'll tell your breathing rate to slow down. It'll tell you to digest things. It'll tell your liver to secrete things. And it also actually conveys some visceral sensory information from those organs too. So things like bloating or pain or pressure is conveyed through the vagus nerve. Now, a couple cool things about this guy. His axons run through the jugular foramen, right next to the jugular vein. Kind of cool. And one thing that can happen with the vagus nerve is you can accidentally overstimulate the vagus nerve. When you overstimulate the vagus nerve, what it does is it causes a massive parasympathetic response. Where this is most obvious is in your blood pressure. So when you relax, your blood pressure goes down, right? And when your vagus nerve kicks in, when you're overstimulating it, your blood pressure drops like a rock, and so do you. When your blood pressure drops, you pass out. That's called vasovagal syncope. Vasovagal syncope. So vaso, blood vessels, vagal, vagus nerve, syncope means fainting or loss of consciousness. This is very different from a traumatic brain injury, by the way. A TBI results in loss of consciousness for 5 to 20 minutes. A vasovagal syncope will last like a couple seconds to maybe a minute, if that. And usually people with vasovagal syncope, unless they have underlying health conditions, will pop right back up. They'll recover within half an hour or so. What causes vasovagal syncope? Well, there's a couple things that make sense and there's a couple things that don't. So one of the major triggers for vasovagal syncope is the sight of blood in people. And I know you're going, hey, why would seeing blood trigger the parasympathetic nervous system? That's all about relaxing, right? Well, we don't know. We just know, see blood, vasovagal syncope, you go down for the count. At least some people do. You can also stimulate vasovagal syncope by, there's no delicate way to put this, by pooping. So when you poop, you put a lot of pressure on your abdomen and on your internal organs and on your vagus nerve that supplies those internal organs. So by pooping, you activate your parasympathetic nervous system. Your heart rate does go down when you defecate. Digestion does speed up. Your blood pressure does drop. I keep saying this, but I had a student a couple years ago who had a genetic disorder where his heart would get stuck racing. Like his heart would start racing at like 130 beats per minute, even though he was sitting totally still. And how he fixed it was just by going to the bathroom. What a hell of a way to fix it, huh? Anyways, enough with that. Now, if you damage this, there's no coming back. You're dead. I love that phrase down there, incompatible with life. All right, number 11, the accessory nerve. The accessory nerve is a weird one. The accessory nerve is the only cranial nerve that does not originate from the brainstem that does not originate from the brainstem. There we go. Had to get it out there. Where does it originate? It actually originates from the cervical spinal nerves right there. C1 through C5 if you really care about it. And this is the part that makes no sense. And this is still the part why it's considered a cranial nerve. Well, all these little roots join up to form the accessory nerve. The accessory nerve goes up into the skull and then goes right back out. It does not have another branch that goes off up here. There seems to be no purpose to it. That's just how we develop. So that's why it's considered a cranial nerve. It goes through the skull, even though it doesn't originate there. So when it comes back out, it supplies the muscles of your neck, the muscles of your upper back, and some parts of your shoulder. So this guy's going to be motor, and specifically somatic motor to all of these skeletal muscles. If you really want to be specific, you can even list which muscles, the trapezius and the sternocleidomastoid. If you damage this nerve, and you can by sleeping weird, by cracking your neck, by damage to this nerve is pretty common amongst secretaries, people who have to spend a lot of time on their phone, right? You ever see those people who kind of like prop up their phone with their shoulder? Yeah, that's damaging the accessory nerve right there. Well, you're going to have problems controlling that trapezius muscle and that sternocleidomastoid. You're going to have shoulder droop. You're going to have weakness turning your chin. That's what the sternocleidomastoid muscle does, right? You also might have some pretty intense pain as a result of this too. So that's our accessory nerve. Last cranial nerve, hypoglossal. So hypo means below, glosso means tongue. And I'm sorry, I think I accidentally left all this text on here. I meant to just give you the picture. The hypoglossal nerve supplies the tongue. Surprise, surprise. Now, I know what you're thinking, oh, taste! No! The hypoglossal nerve supplies movement information to the tongue. So if you can wiggle your tongue, if you can roll your tongue into a taco, those of you guys who can do it, you know what I'm talking about. Oh, that's because of your hypoglossal nerve. And because you use your tongue, you use the muscles of your tongue to swallow, to articulate speech. If you damage it, you have difficulty swallowing, you have slurred speech. And you can't, like if you stick out your tongue, you can't actually point your tongue very well because you can't control the muscles in there. So testing for this one, real easy. Just ask your patient to stick out their tongue and see if it's pointing kind of offside, off in one direction or another. If it's pointing off in one direction, the hypoglossal nerve on the other side is damaged. I figured you guys might appreciate this right here. I got this from a nursing website. And this shows a face and approximately where these nerves innervate. So you see this 8 right here for vestibulocochlear. You see this 11 right here for accessory. Here's a 7 for the sides of the face. Here's a 5 for the center of the face. 3 for oculomotor, right, for controlling eyelids and extrinsic muscles. 2 for optic. 1 for olfactory. Somebody put a lot of thought into this. And then if you want to click on this link down here below, this again is to a nursing website. This tells you more about how to actually test each cranial nerve and make sure that it's still working. Why would you want to test a cranial nerve? Well, the cranial nerves are often one of the first things to start decaying with age. So testing cranial nerve function is a really, really common part of a general checkup for someone who's a little bit older. And we often test cranial nerves after somebody's been in a traumatic accident, like a car accident, make sure nothing's been damaged that way. So again, just if you want to give that a read. Alright, I'm going to save our spinal nerves for part 2. That's okay with you guys. And I'll meet you at part 2.